Okay, I think we can just let people trickle in, but it's so nice to meet you. I'm Verena. I'm one of the co-chairs for the S&P SIG, and we do this webinar series every few months to just get people more involved in, the oncology world, and we're really excited to have you today. So I figured we would just start with some introductions if you want to go ahead and tell us a little bit about you and what you do.
Yeah, awesome. Well, thank you again for having me on. I love APT oncology and everything that the Academy is doing for students and new professionals, and obviously well beyond that. So I'm really excited to be here tonight. So my name is Alex Hill. I'm a physical therapist. I practice in outpatient setting. I'm in Jacksonville, Florida, and I specialize in pelvic health, oncology, and lymphedema. And then I have a side business and I do online content creation and clinical education courses for clinicians.
Awesome. And your content is amazing. I frequently refer patients to it. So even if it's
Thank
extra
you.
stressful, I think it's really great and really makes care more accessible to people. So we want to make this pretty casual, and there's quite a few people on, so we want to open it up for questions as we keep chatting. But my first big thing is, how did you really get into pelvic health and or oncology pelvic health to be more specific?
Yeah, so I went to school at University of Florida, which go Gators, national champions as of last night for basketball. Very exciting game. But I went there for PT school, and we had just a couple hour lecture on pelvic health, and it was more kind of differential diagnosis, a kind of basic understanding of some of the conditions, but not more than that. And it was at my first clinical rotation that was in an outpatient setting at Shands, and it was an orthopedic rotation, but we did have some pelvic health and oncology therapists there. And so my CI was out for a day, and I wanted to, like, what do they do behind the doors? Like, there's crying, there's laughing, there's always talking. Like, they'll come out in the gym and do things. So go behind the door, like, what do they actually do? And so I shadowed with them. And for me, it was so immediately and immensely profound with the impact that we could have in just a single session with educating our patients and validating what they're feeling and what they're experiencing. And I just remember some of the patients that day, and they had been going on for years or decades, even, of having leakage, of having pain with intimacy, with dealing with lymphedema, and like just all of these different things. And people had just been telling them, oh, it's fine, like that's normal, have a glass of wine if you're having pain. And it was just completely unacceptable to me that, like, these people were suffering, and there could be so much that could be done by just, again, listening, educating, addressing the body. And so that was my first, like, I immediately fell hard for pelvic health and oncology. And for me, it was interesting because um, a lot of people specialize in either pelvic health or oncology, but the therapists that I followed, they did both. And so I just thought that that was incredible to see the interaction and interplay and really how these two worlds kind of collided together. And so that was, again, my first introduction to it. And within PT school, that those are the two primary areas that, like, even outside of class, I kept trying to find more research articles on. I kept trying to network with people. I joined APTA Pelvic. I shadowed more. I did everything that I could. Like, I just could not get enough of that information. So for me, like, that's how I knew, like, this is what I need to be doing. I need to be in pelvic health and oncology. And so I had was able to get an 8-week clinical rotation. It was in pelvic health. But I really didn't see the number of people within pelvic health of these complex cases with men and women, with different genders, with these really complex medical conditions, with oncology background. And so for me, that's when I also knew, because this was my last rotation in school, that I needed to also do a residency. And so I'm more than happy to talk about my experience with residency. But that for me was, again, my introduction to it. And then I did my residency at Duke, which was also on the Final Four. I did my residency with Duke in women's health. That did include oncology. My first week there was actually getting my CLT certification, which was really cool. And so I've been in practice now for 11 years, and this is all I've done that whole time.
No, that is awesome. And was there a reason you went more into the women's specialty than an oncology residency, or was it just that was more accessible?
So at the time, there were no oncology
That's what I
residencies,
thought. Okay.
period. So, and even then, when I was applying for residencies, I think at that time there was maybe only 7 or 9 accredited women's health residencies at the time in the country. So even then, there were not a lot of options available. But yeah, but luckily within women's health, that includes not just, pregnancy, postpartum that a lot of people think of. It's really across the lifespan of continuum. So that includes with puberty, that it does include pregnancy, postpartum, that includes osteoporosis, it includes breast cancer, gynecological cancer. And then within that, men are included with that too. So it is a misnomer of women's health when it really, I mean, the academy has now changed its name to APTA Pelvic Health. That's a whole other story, but
Oh, that's wonderful. I think it would actually be great if we do have any students who are here just talking about your experience with residency in general and how you feel like it
yeah,
helped you kind of transition to what you're doing now.
yeah, absolutely. So I think for me, one of the biggest indicators that I felt like I needed a residency was, again, I had the 8 week rotation where I had some exposure, but I knew that there was so much more that I wanted to be able to treat and to do. And I knew that I wouldn't get that just out of the gate from other people that I had talked to who had recently graduated. If you wanted to get into pelvic health, it was basically like pelvic health and ortho. Like it was always going to be a split. It was hard to say for sure, like what would the mentorship look like? Which APT Oncology has an amazing mentorship program also, that has grown a lot over the years. And so for me, that was the first indication of that I wanted to do a residency. But also for me, looking 5, 10 years out from graduation and what I wanted my career to look like, I also wanted to be involved with research of some kind. I wasn't sure at that point if I wanted to go back and do a PhD or an EDD or something like that. But I knew that I wanted to do some type of research. I knew that I wanted to be teaching in some capacity. I wanted more than just being a clinician. And so looking at the residency programs, and again, there's a lot more available now, and especially in oncology, it's incredible. And what those opportunities are within each of the residency programs. There's some that I didn't apply to, or maybe that weren't as high on my list of places that I applied to because they maybe weren't as strong in prostate cancer, for example, or in teaching, and like you weren't actively teaching in DPT programs. And so those were some of the things that for me, I knew again, like 5, 10 years out, I wanted to get to these places. And so to get there, working backwards, I had to start with a residency. And so that really helped me really launch my career with the networking that was available, starting to teach early on. The mentors that I had were already involved with APTA oncology, APTA pelvic. And so getting that first foot out the door as a new grad was absolutely incredible. And really, like I said, I was able to launch my career a lot earlier and reach my goals.
No, that makes sense completely. That's wonderful. Can you talk a little bit more about how treating the oncology population is a little different than just what is a more general pelvic health population?
Yes, absolutely. So within oncology, right, we have the diagnosis of the point that somebody is a cancer, or determined to be a cancer survivor, and then they're a cancer survivor, thriver lifelong. And so with that comes all of the side effects of their cancer treatments. And those, as we know, can be acute side effects. These can be late side effects where they develop later on, or they can be long term where they've developed during treatment and then they continue past the time of finishing treatment. And so when we look at some of the pelvic health conditions, for example, pain with intercourse, we'll just take that as an example. Somebody could have that with cancer and cancer diagnosis and treatment, or they could have that without cancer diagnosis and treatment. And so when you add that extra layer of oncology, and not even just the oncology medical treatment and side effects, but also the psychological, the socioeconomic burden that it has, how that changes maybe their relationship with their partner or their spouse. That's a whole other layer of things that as pelvic therapists, we need to address and get trained up on and be able to address those kinds of things and really understanding how does, chemotherapy impact sexual function? How does chemotherapy impact CIPN, chemotherapy induced peripheral neuropathy? And then how does that then impact their sexual function? And so there's a lot of different things that we can educate people on in terms of, we'll stick with the intimacy side of things, with positions, for example, where maybe they like to be quadruped, but now they have CIPN and it's really painful for them. What are some ways that we can either address the CIPN or maybe change positions? Like, what are other ways that we can get creative that they can still be intimate with their partner in a fun and playful way? Or with colon cancer, for example, if they've had a hemicolectomy and they've had part of the colon removed, again, that can lead to fecal incontinence, which could be present or not present with cancer treatment. And so we not only need to look at the anatomy and the physiology and the pathophysiology of what's going on in itself, but then on top of that, what's the impact of losing half of your colon? There's a lot less transit time for the stool to move through and to actually get formed. There's the chemotherapy. So there's a lot of other factors that we need to layer on top of a potentially already complex diagnosis that we're kind of having to tease out, where is this coming from anyway?
No, that makes sense completely. And I know, like you said, with many cancer treatments, it can include radiation and all these other things that can directly impact. And you're already, you treat lymphedema, obviously, that can impact as well. So I think it's really great to have a good knowledge in both. It really can impact our patient care. Are there any
Yes.
special considerations or precautions with this patient, with this specific patient demographic that you think, for someone who's a newer practitioner or a student, things that you would really want to be aware of when treating?
For pelvic health within oncology.
Hmm.
So I think, and I feel very strongly about this, I get on a lot of soapboxes too, because I think a lot of things within oncology and pelvic health are so important to talk about and to advocate for our patients for and for ourselves as therapists. But a lot of times we're taught just like cancer is a red flag, but okay, hi, we're going to be in oncology PTs, PTAs. Like, this is not a red flag. Well, I mean, it's still a red flag, but this is our population. It's more than just a red flag. And on the pelvic health side, screening for bowel and bladder issues, right? Like, this is something that, okay, like, make sure you check off and that you've screened these things with your patients, but this is now something that is something that a lot of patients are going to be experiencing, especially after some type of pelvic cancer treatment. And so, not just simply screening for bladder, bowel issues, pelvic health issues, but then taking that a step further and saying, if you do, okay, this might not be an automatic referral back, asking more questions about those symptoms and either starting to address them yourself, right? We can talk about toileting things. We can talk about fiber and diet, that kind of stuff. And also making sure that you have referrals available for pelvic health therapists that you'd be able to refer back to or that you'd be able to collaborate with. So I think that's probably the biggest thing is recognizing that cancer in and of itself and bowel bladder issues in and of themselves, it's more than just a red flag. You have to really look at that holistically and how can we address all of that together. Did that answer your question?
No,
I can expand
absolutely.
on that. Okay.
Absolutely. I think that's really great. And I actually think that kind of leads us into a little bit more where it's how often are you communicating with the medical team? How do you feel like, rehab really plays a role in the interdisciplinary care with, oncology patients in general, but even more so with pelvic health specifically?
Yes. And so I think that's a really great question. I think even so, like I said, I've been in practice 11 years now, which is hard to believe. Um, but at that time when I was first starting out versus now, it's completely different in terms of how integrated rehab is in that multidisciplinary team. I think historically it's been more of either oncology team doesn't really believe in PT. I put that in quotes for those of you who are not watching. They don't believe in, rehab. They maybe don't see the benefit of it. Maybe they think that, oh, the patient's already overwhelmed with so many things. Like, let's not worry about that yet. And now with the COC, with cancer accreditations, rehab has to be integrated in the medical team or in that multidisciplinary team. And I think that, going for that accreditation, which a lot of large hospital systems have, that was a huge step in getting us there and getting us a seat at the table of, hey, like we actually have to be here to keep accreditation, and help to open up a lot of doors a lot easier for communication about what rehab does, and not just PT, but OT, speech as well. And so I think that's been really helpful. And also just some of the just growing literature that we have on the benefits of rehab, and especially its benefits early on. So prospective surveillance model, especially Stout et al., like I think it was 2012 when that was published. And again, like we need to be showing up for our patients, and they need to be getting referred to us at the time of diagnosis. We're seeing definitely with the breast cancer population, because this is such a robust area of research, that in general, most breast cancer centers, they are sending their patients over to rehab pretty soon after diagnosis, and they're able to get in for those baseline measurements. We're able to follow them through treatment and well beyond. On the pelvic oncology side of things, unfortunately, we're still a little bit behind on those. We are starting to get some more standards available. But even at my own institution, it is continually educating and talking with and communicating with the gynoncs, with urology, with the colorectal surgeons, and radiation oncology on why people need to be getting referred sooner versus we're fighting an uphill battle when they're 6 months out from treatment. So we do have, especially in some of these larger hospital systems, these larger cancer centers, and I've talking with other colleagues around the country. In general, the communication has significantly improved. The collaboration has significantly improved, and definitely in terms of individual communications, we have a lot more communication when the patient's in active treatment. We need to be on the rehab side, we need to be looking at what those blood values look like. We need to be looking at when is the patient getting chemotherapy, when are they maybe going to be at that nadir where they have that really low point of their blood counts from chemotherapy. We need to be looking at and coordinating with the radiation therapy and not having them have a session within 2 hours before or after, because they shouldn't be exercising in that time period right before. And so really communicating and being part of that team is going to be really important for our patients. And then as they get farther out from treatment, they have less point of contact with their providers, even though it might stay fairly consistent with us, but our communication with the provider would likely decrease as well, unless we're seeing something that is abnormal, something that's red flag, something like, hey, like we need to get them back in, get a second set of eyes on these. But in general, a lot of communication during the active treatment phase for sure.
No, I think that's wonderful. I think you're right, especially in regards to how much things have changed over the last few years.
Mm-hmm.
I mean, just as research comes, there's more communication, more understanding, even something like vaginal estrogen and how much it's changed in regards to prescription
Preach.
and things like that when it's really evolving and it's really exciting. So I guess this leads to another question where it's like, what's one thing you really wish healthcare providers understood when sending patients to pelvic or oncology rehab? And it could be something like, pelvic PT is more than a Kegel, or,
Right,
anything
right.
specific that you can think of where you just wish every provider knew and wish it was something that most, PTs could go back to providers and say, hey, XYZ.
So I think this is going to be really hard to keep this in one sentence because there's so many things, but I would say ensuring that they understand how broad and how deep our scope is, regardless of if that is oncology or pelvic health. The knowledge that we have getting into these specialty fields is, again, so broad and so deep. It is more than, for example, oncology, it's more than just doing exercises for weakness. It's more than on the pelvic health side, like you said, it's more than just doing Kegels for leakage. It's more than with radiation therapy. It's more than just sticking a dilator in, which I've unfortunately that verbiage is still said to a lot of patients where you just stick it in. Like, no, that is also really traumatic. They just got done with all of their treatment. You're telling them to just stick in a size medium dilator when really they need like an extra small dilator. We have the lens on the rehab side of really that total holistic care that we're able to provide. We're able to do motivational interviewing within your scope of practice and training. Like we can provide nutritional education. I took additional nutrition courses to be more confident in being able to provide that education. We're able to do so much more for our patients. And anytime I meet with a urologist or a gynonc and explain to them what we do, they're like, oh my God, you do all that? Like, how, like, this is crazy. Like, what is your training? And then that opens up more conversation, or even just having a patient. So, right, we all have had providers who, again, even with the patient asking and begging for referral to rehab, and the doctor's still saying, no, like, you don't need it. It's fine. Like, just wait, it'll get better. And then they come anyway, right? Like, I'm in Florida, we have direct access here. And so they come anyway, and then they go back to their provider and they say, oh my gosh, they helped me with A, B, C, D, all the way to Z. And then that's what's going to help start getting more referrals in, because they're realizing how much we can do for our patients and, again, what our knowledge and skill set is. So I think that'd be the number one thing.
I think that's perfect. That's really good way to summarize it because it is a lot. You did a great job. I actually wanted to circle back when we were talking about residency as kind of the path you chose. Are there any specific courses or different types of continued education you'd recommend for someone who's maybe already a little later into their profession but wants to get more into oncology and or pelvic health?
So there's not a lot of courses that bridge the two, oncology and pelvic health. There's definitely more from even when I was first practicing, where there was maybe one at the time. And between cost and taking time off, and as a resident, you don't get a lot of time off in general. Or even if you're a more seasoned clinician, you're starting to get into these areas, like you don't have a lot of time. So it can be hard to find, especially those continuing education courses. I don't know if I'm allowed to promote different courses here, but there are a lot of courses that are available, both in person and online. A lot of resources through APT Oncology, and even beyond just the courses. Like I mentioned before, APT Oncology, the S&P, has a phenomenal mentorship program where you can get matched up with somebody. I believe they're still trying to match you with somebody who has similar interests, similar geographical area, that kind of thing. um, you know, different Facebook groups. There's a lot of different ways to still learn these skills, and finding people who are doing what you want to do and talking with them and bringing cases to them, and, just having that collaborative communication and working on these different cases and seeing what courses they took and that kind of thing. But like I said, especially with pelvic health and oncology together, there's a lot more courses that are available now, which is, I think, really good, because I think that has historically been another barrier for patients coming to see us, is there haven't been a lot of oncology therapists. I mean, we only became a board certification, what, 6 years ago?
I
I'm
think
trying to think. I
you're,
took
I
mine,
think you're right.
right, because I was in the second class, the second cohort that took the exam. Fun fact about me: I took my board certification for oncology on Friday the 13th, 2020. Came out of the exam. I was going to meet up with my husband at Guinness. I was living in Maryland at the time, and I'd been studying for 8 months, and like, we're going to get a beer to celebrate. We're going to get some great food. Like, we're going to like celebrate. No, I came out of the exam, turned on my phone, all these text messages, notifications, like basically the entire country had shut down.
Yeah,
So that's how I will remember taking this exam, Friday the 13th, and everything shutting down.
you took it before. You got it done. Okay, I'm with you. No, I think the mentorship is a great plug as well for anyone who's listening and is really interested. Feel free to chat. We're happy to connect you as we're still putting it together, but I do think we can connect you with the right resources because it is such a wonderful access thing and it's free through the academy.
Yes.
I
Yep.
also wanted
And
to just,
then,
sorry, go ahead.
sorry, no, I was gonna say, and then there's also the map that's available too. I think there's still like the map or the PDF that's available for clinicians who are taking students as well in clinical rotations. For those of you that are students, there's a great resource on there too if you're trying to find someone or a specific state or area or something. I believe that that's still available too on the website.
I think so too. I wanted to open up the chat for anyone who had questions as we kept chatting so we can make sure to get to them. So if anyone has anything, please feel free to throw it in the chat. But in the meantime, can you just tell us about a time where, physical therapy intervention really helped with a specific patient? If you can just kind of run us through a general patient case you had that you can think of. I know you've had many, many over the last
Yeah.
11 years, but just something where you feel like, having my knowledge in pelvic health and oncology really made this difference.
Oh, that's a good one. There's a lot. Is there, I'm gonna open it up in the chat. Is there any particular diagnosis that you'd be interested in? So like I can think of like prostate cancer, testicular cancer, gynecological cancer, colorectal cancer. Is there anyone that people are more interested in hearing about? If not, then I can talk about a recent case that I had that I just presented on at a conference that's gynonc. I don't see anything in the chat, so I'm just going to keep talking. But if you have suggestions or any thoughts, feel free to put them in the chat. Um, so I had a patient who, and I just presented this at a conference, but I saw her last year. She had endometrial cancer. She was diagnosed in 2023. Yep, gynonc patients, what the rehab looks like after perfect. Yes, I can definitely do that about radiation. And this case actually has radiation. So she had, like I said, endometrial cancer. She had a hysterectomy. She had lymph node dissection. She had 6 weeks of chemotherapy. And then they had recommended her to get brachytherapy. So that would be the internal radiation therapy. So there's basically a tandem that is inserted into the vaginal canal. Basically, for her, it'd be going to the vaginal cuff since she had the hysterectomy. And then that radiation is placed directly at that site. And for this patient, she had had such severe narrowing of the vaginal canal, what we call stenosis, that if this would be normal, hers was about this big. And so she, one, wasn't able to physically tolerate or get the brachytherapy completed. And so she ended up getting the external beam radiation therapy. And so for this patient, again, on the oncology side, I needed to be mindful and to understand what's the impact of the hysterectomy, the lymph node dissection, the chemotherapy. What does that do to her? And this is her even before coming in the door. Is she going to have balance issues? So she had carboplatin and Taxol, so platinum and taxane. So typically going to be leading to some CIPN and other issues. And so all these things that I'm thinking about, like with her coming in, with the external beam radiation, is she going to be having, limited hip range of motion? Is she going to be having fibrosis? And so she came in, and like I said, the tissues were so narrow, and she was at the point, and I'll never forget this. She came in, she was very fearful to come into physical therapy. She didn't fully understand why she was there. She was in a situation where she was given a medium dilator and just to put it in kind of thing. I have those in quotes again for people not watching. And she was so fearful and having so much pain with her pelvic exams that she told me that she would rather die from recurrence of her cancer than deal with getting a pelvic exam again to check for it. And that like her world was shattered. And then to now have to keep getting these pelvic exams or forcing these exams, so for her, this was just a really traumatic experience for her. And so that first session, it was just getting her to trust me. It was motivational interviewing, is validating her feelings. It was giving her options of what physical therapy would look like. again, it's not just sticking a dilator in, it is getting to the root of that fear. And how do we change those brain synapses and how your brain and nervous system are responding to being in a clinic? Because her blood pressure would shoot up even just walking into the clinic. Driving up to the clinic would send her into panic. And so it was really addressing a lot of those things first and talking about some of the other side effects that she was dealing with before we even got to doing anything at the pelvic floor. And so as she felt more comfortable, then we were able to do the pelvic exam, could really see, how narrow the vaginal canal was. The tissues were very pale. We typically see that after menopause. And so they're, with the drop in estrogen. And so it was also educating on doing vaginal moisturizing program. Would she be appropriate for, like you mentioned earlier, the vaginal estrogen cream? And so we started with just using a finger first, with her getting comfortable with that, just at the outside of the vaginal opening. And as she got more comfortable with that, and we did diaphragmatic breathing, we did progressive relaxation, we did guided imagery. As she got more comfortable with just, again, not even that far into the vaginal canal, we were able to use, and we got her a set of multiple sizes of dilators. So one that was really, really small, like smaller than my index finger. And so she was able to progressively work through those dilators, to the point where when we discharged, she had built up the courage and confidence to be using a size small plus almost a medium dilator. And she felt confident and comfortable enough to be able to go get a pelvic exam that she had been avoiding for almost a year. And so she was able to get the pelvic exam done. They used a small speculum. So a lot of people don't realize there's kind of the regular size speculum, and then there's a small, almost kind of pediatric size speculum. And so she was able to tolerate that size small speculum and get, like I said, her first pelvic exam. And so it was just incredible, again, just seeing that positive change with her, that validating her feelings. Like, it's okay to be scared, but like, how can we work on this together? And walking with your patient hand in hand, and helping them succeed with what their goals are. For her, she wasn't sexually active. She did not want to be sexually active. She was obviously postmenopausal. She wasn't using tampons. She wasn't having leakage. She didn't have any balance issues. Her hip range of motion was fine. Everything was perfect. It was her only goal was to be able to get pelvic exams. And that for me, like, I think is a great just example of that intersection of the oncology side and the pelvic health side, but also us in rehab as educators. And it's, kind of the quote, more therapy side of physical therapy, but how do we incorporate that into our practice to help our patients?
No, I think that's great. That's a really wonderful example, and just helping with the confidence building and everything there. I'll keep
Yeah.
waiting for people to throw in some questions in the chat, but in the meantime, let's keep going. Where do you really see the field going in the next few years for both oncology and pelvic oncology? Like, what is your hopes and dreams in addition to what you think is actually going to happen in the next few years?
So I would like to see more crossover. And that's not even just between pelvic health and oncology. That is neuro and oncology, or pediatrics and oncology. I love our specialties. I wouldn't change it for the world. I love how specialized I am. The last time I treated somebody with a post-op orthopedic ankle was when I was a student. This was like 13 years ago. Like, that's not my jam. Could I do it? Sure. But like, we need people in these specialty areas. But I think that we need to in the future, because I think as a profession we've focused so much on either being a generalist or being a single population specialist, that now we're kind of like losing some of these middle ground patients. And so and so with that, then especially with our cancer survivors, like, they already have so many appointments anyway, they already have so much financial cost associated with all of their cancer care and their appointments. Like, now we're having to refer them to another provider to take care of the pelvic health side of things, right? So my goal would be that, what I would love to see with the profession is that oncology therapists are able to at a minimum, better screen for pelvic health conditions and start to treat people. You don't have to do internal work. That's okay. It's not for everybody. But at least be able to start with things. And then on the pelvic health side, for pelvic health therapists to know what lymphedema looks like, and to be able to learn how to screen for that. And again, not necessarily become a CLT, but like you need to know what that looks like, and to start some general interventions to understand what chemotherapy does to the genitals long term, what radiation therapy does. So I would love to see, again, more crossover between these specialties, to provide better care for our patients, especially, like I said, there's so many barriers to care and to access to care for our patients. We're seeing reimbursement rates and insurance getting cut and Medicaid getting cut. So it's, we have to be able to show up for our patients. And what that means, I think, as a profession, is we have to be able to cross train and to treat other things within our specialty as well.
Yep, couldn't agree more. I actually personally went from working at a comprehensive cancer center to now starting to see a few ortho patients and
Yeah.
more pelvic. And I'm like, oh my gosh, it's been a few years. I've got to go back to PVP notes because I don't remember a lot of this. And I haven't seen a total knee in years. And I couldn't agree more. I think it would be great to, it's wonderful to specialize, but to also have more of a generalist outlook too, I think can really go a long way because a lot of oncology conditions are orthopedic conditions. So being qualified and, confident in treating both is super important. And I actually think that
Yeah.
goes to this question we've got here, which is, what are your ultimate goals for how we can integrate oncology and pelvic health into the DPT curriculum?
Oh, that's multi-million dollar question. I mean, and there's been some great work on this already in presentations and in literature already, especially with Dr. Lori Borwright and the OU crew at Oakland University, with how do we integrate this into the curriculum, and how do we do that well? Again, for me with pelvic health, I had like a 2 or 4 hour lecture on, again, it was more differential diagnosis of SI pain and red flags, that kind of thing. And oncology, I would say it was maybe a half a day, or I'll give it a day lecture. But again, like a day lecture for oncology, like that's just not okay when we look at the millions of people who are going to be cancer survivors and who are cancer survivors. And I've talked about this with faculty at different DPT programs, and really it's challenging because with especially like captain and accreditation, that kind of thing, like there's certain things that as DPT programs they have to do, like you have to do this. Um, and how do you fit all of that in to become a entry level PT that can see, anything that walks through the door in general, but still be able to provide these? I would argue, and I know others would argue, that pelvic health and oncology should be integrated into all of the courses. Within pelvic health, like why isn't that in interventions and modalities? Like we're already talking about E-stim anyway. Can we just even like a slide or two? Let's talk about how E-stim and biofeedback can be used vaginally and rectally for strength, for pain, for urgency. Like we should at least be aware of these things, going out into the field. So again, I think I could talk about this for a long time. That's a very good question. And I think that that is very hard to answer on how we can integrate those in. I know other programs. So at Duke, with their PT program, they have different electives that people can choose to take. And so they have a pelvic health elective, they have an oncology elective. And so I think that's a great way for programs to be able to integrate that in to their curriculum. And that's a good program to kind of look at how they're doing that. But again, I think that that's just very challenging. And then but again, I would argue that these should be integrated throughout the curriculum anyway, but what
I
do I
agree.
know? No.
I agree. We'll keep going. This question says, I'm currently on clinical and interested in working in peds onc. Have you had any
Yay.
experience with pediatric oncology patients or any advice for treating steroid-related incontinence in this population?
I First of all, yay for you being on clinical. That is awesome. This is Bree. If you don't mind unmuting, are you on an oncology? clinical?
Um, so I'm doing it's literally peds onc. So I see patients inpatient and outpatient, and
Hmm.
a lot of times there's a continuation of care or they miss their outpatient visit because they're inpatient. So I get to see them
Mm-hmm.
still while they're in the hospital. So it's very
That's
unique.
amazing. Yeah.
Yes.
Oh, that's really cool. I personally don't have any experience with pediatric oncology. I've had one case of pediatric genital lymphedema. That was not, it was primary lymphedema. I kind of joke like if someone's old enough to see a PG-13 movie, I will see them. So I don't really do a lot of peds. But in terms of the steroid related incontinence, I'm not as familiar with that specific type of incontinence. Is it related to just the steroid use if you know?
It was just something my CI and I were talking about because she asked some of the outpatient pelvic health therapists what they would advise, and it kind of was just a general core strengthening program. And we're like, well, these kiddos have steroid myopathy, and that's kind of what's causing their
Right.
incontinence at the same time. So it's always like a specific type of drug that they are seeing it in. I haven't seen it personally, but I'm sure it's something that will come up in the future.
Yeah, that's if you want to email me, I'm now very curious about this. I'm definitely like a rabbit hole person. You're more than welcome to email me. I can put my email in the chat. And for anyone else too, I'm happy to answer questions after. Um, but yeah, I would imagine if it's more like the steroid myopathy induced, I would imagine probably doing a lot more like glute adductor like kind of overflow work on top of doing the pelvic floor exercises. Um, would likely be helpful. And then with steroids too, you think about the increased just volume as well. So managing kind of the fluid overload or kind of volume that they might have as well. Especially if there's like a lot of nighttime issues with, elevating the legs, doing some just kind of general remedial exercises to help with any, again, kind of that steroid swelling that can happen as well might be helpful. But like I said, go ahead and email me. I'm very curious about this now too.
Thank you.
Yeah,
Perfect.
absolutely.
Okay, our next one we've got non-pelvic health onco PT here. What are some screening questions
Yes.
you recommend a non-pelvic therapist ask to help identify pelvic floor issues?
Oh, that's such a good question. So there is I don't want to misquote it. It's the Cozine screening tool, I believe. Let me just triple check that that's the name. If you look that up, yes. Yeah, Cozine pelvic dysfunction screening protocol. It's not really a protocol if you look at that like definition wise semantics, but if you just Google that really quick, there are some really good questions that you can ask. Um, and then beyond that, I would say depending on the patient that you're working with, some general things would just be, and sometimes it's also like how do you bring this up, especially if you're seeing them for something not pelvic health related. And a good way to bring that up is, one, be mindful where you're asking them this. If you're out in the middle of the gym and they're on a new step next to two other people on new steps, maybe not the best time to bring up like, hey, you peeing your pants right now. So just being mindful of where you're talking with them, but saying something along the lines of, with the type of treatment that you've had, it's not uncommon for there to be some pelvic health concerns that could be issues with bladder, bowel intimacy, pain. Is it okay that I ask you some questions? So always asking permission first. Um, a lot of times people aren't even asked about pelvic health symptoms, especially sexual health. There's been some literature, especially with physician residents and physicians and oncologists, and they're not asking patients about pelvic health symptoms, especially sexual health. Some of those reasons are because they're not comfortable. If they do ask, they don't know what to do to help them, or they don't know who to send them to. So coming back to your question from earlier, like this is where our communication and advocating for a profession and what we can do to the oncology team is going to come in really handy. But again, I would kind of bring it up that way. And then asking, do you have any bladder concerns? That could be leakage, urgency, not feeling like you completely empty, bowel concerns like constipation or not being able to hold your stool, any intimacy concerns, and you can just leave it just at that. You don't need to get into the nitty gritties like we do in pelvic health, where I want to know what position is comfortable for you. And then you can also screen for prolapse, especially if they are at risk for prolapse, so where the organs start to drop down. So just asking if they've had any sensation of pelvic heaviness, fullness, anything that's maybe dropping down. Those would be things that you could at least just ask for a screen for. And then depending on where you're practicing at, you could also just include this as part of your intake forms as well, of checking like any pelvic health concerns, and then you could always just list them in brackets or something like that as well.
Perfect. I think that's really great. I think even with sexual health in pelvic health, sometimes we're the first, I feel like, that can be asking a patient, even if they had a surgery in in that area. And it's just something
Yes.
definitely continue to be brought to light. And like you said, in a nice and private area for sure.
Yes.
Amanda gave us a good follow-up question. So it sounds like you think it would be beneficial for onco-PTs to have a foundation in pelvic beyond screening. What are the foundational things you should know slash learn?
Everything. No. So I would say some of the biggest things would be how to screen for pelvic health concerns like we just talked about. Another easy one would be screening for, can they do a Kegel or pelvic floor contraction correctly? If you all are so open to doing so, we can practice that right now really quick. So this is called the coccygeal, and of course the pelvis everywhere I am. My poor husband's pelvis is everywhere. But the coccygeal movement test. So you're basically just going to have your finger on your tailbone. So if you want to try that right now, you're just going to stay sitting, but just put your hand on your tailbone. I love seeing people shifting. I can tell that you're doing it. And then you'll do a Kegel. So if you've never instructed on a Kegel, you're just going to imagine like you are trying to stop the flow of urine. So you're just pulling the pelvic floor up and in, or pulling the rectum up and in, or the vagina and penis. So pulling everything up and in. If you're sitting, you should feel it pull away from the chair, and then you're going to relax. So for you as a therapist, if you're feeling the tailbone move caudally, so it's moving forward, then you know that they're doing it or you are doing it correctly, and then you'll relax. If you feel them pushing out, you know that they're bearing down and not actually doing the Kegel. So even if you're just screening, can they do a Kegel correctly, and even just getting them started on just start on some just gentle Kegels, even to help with lymphedema. There can help with genital lymphedema. That can be really helpful. And then I would say some of the more common educational things and behavioral education things would be very helpful for onco PTs to know. So that would be toileting positioning, especially for people who have constipation or have pelvic pain. So using like a squatty potty or a step stool, what that does, that brings the knees above the hips. And so that opens up that anorectal angle, makes it easier for the stool to come down. So something like that. Educating on fiber recommendations if they're having loose stool or if they're having constipation, fluid intake. So especially if they're having urgency, if they're having cystitis or hematuria, educating on reducing some of those bladder irritants, like I'm being bad, like carbonated water, or coffee, tea, anything acidic, carbonated. Those are all things that can irritate the bladder, and make urgency or leakage worse. So just really pushing more water at that time. But those I would say would be some kind of basic things, is just screening for it, screening for, can they do a Kegel correctly? And then some of those, again, kind of more foundational educational things that like almost like wellness education that we can provide patients.
Awesome. I think that's perfect too. Okay, I don't see any more chats, but let's see. I have a question that I just love to ask every
Yeah.
oncology therapist in general, but how do you manage burnout and, compassion fatigue and things like that that just kind of come with working with this population?
Great question. Counseling is the number one thing that I would highly recommend, especially if you can find somebody who specializes or has experience in working with healthcare providers, and especially in oncology and pelvic health and neuro. So, and we look at, I'm glad you asked this, because even, of course, research, um, and we need more research and rehab side of things, but even on the medical side and nursing side, the top specialties that burn out are, guess what they are? Oncology, urology, neurology, peds. So we are doing those. So I think it's really important to manage your own mental health. So, and truly, like, counseling has been really, really helpful for me. And I know a lot of other people, just to kind of process things, but also find some strategies and ways that you can become more resilient, without becoming hardened, if that makes sense. So we certainly have to have, I like to say, not a wall up, right? Like, you can't, personally, I feel like you can't really truly show up for your patients if you have a wall up to protect yourself fully. I think of it more like a screen. Like, we need to kind of let some things in, but like, let the little things in. So you can still see them, you can still interact, you can still feel the feels, but like, it's not to the point where you're getting full blown of everything that's going on, right? Another term that I learned was moral injury in the last couple years. And especially, so like, I work at a safety net hospital, and so we see a lot of people who are uninsured, who are homeless, low socioeconomic status, and the frustrations of knowing that there's so much more that can be done for our patients, but we can't do anything about it. Like, we can, do peer-to-peer reviews, we can find resources and grants and all these things, but it's a system issue, and that's really, really hard sometimes for me. Like, that's more of a burnout than actually working with, like, one-on-one with our patients, because it's so frustrating when they have these great needs and we as a society and healthcare system and insurance aren't able to show up for them. So that for me is really frustrating. So, on that side of things, for me, it is advocating. It is, anytime I see the APTA action emails, I'm like, right, who am I emailing today? Right? Like, we have to show up for our patients. We can't just be angry about it and not do anything. Finding grants for our patients, supporting nonprofits. I try to donate to different local nonprofits here to support our patients too. And then something personal that I do, again, just kind of on a daily basis, is I always try to go out for a walk at lunch, even if it's just like a 2-minute walk, just to kind of clear my head, kind of do my own down training, get ready for the afternoon. And then at the end of the day, before I walk into the house, I open up my car door. I put everything from that day into kind of an imaginary balloon, and then I let that go. It's a biodegradable balloon, but we let that go. And then, like, you have to let it go. You can't let that weigh you down. But that was a strategy that I got from one of my counselors years ago, of being able to let that go and not taking that home to your partner, your kids, your plants, your pets, yourself. And so being able to let that go has been really helpful.
Yeah, those are really great techniques. I think it's hard, especially I'd agree with the system. Sometimes you're not set up for the most success as a rehab provider in general. And I think that's been a challenge for a lot of my peers and classmates from PT school too. And so I think bringing light to that is really important as well. And, practicing what we preach, where we tell patients, do some body scans, do some studies, things
Exactly.
like that. Super important, super wonderful. Um,
Yes.
we have just a few more minutes, and I just wanted to do a really quick plug. If anyone is interested in joining the Academy in any capacity, please also feel free to message. I will leave my email in the chat for the last few minutes if anyone is interested, but we are so happy that so many of you were able to join and ask these really wonderful questions. And Alex, especially, we cannot thank you enough for doing this for us. We really appreciate chatting with you and getting your insight on everything oncology and pelvic. It's been really fun. If anyone has one last final question they want to throw in the chat, I'll leave it open. Otherwise, we can just end here, but I will put my personal email in as well for anyone interested in anything ABTA oncology. We always welcome more people. We'll see. We'll give it a second.
Yes. And thank you again so much for having me on. It always is invigorating and energizing for me. I think that's honestly another way for me to kind of fight burnout, is being involved and finding other ways to give back, because for me, like, that helps fill my cup. So like I said, like, I love doing stuff for AP oncology, for SNP, for students, and anybody that's interested in getting into these areas, because it can be scary, especially if you haven't done it before, you don't have a lot of experience in it. So like I said, you have my email in the chat, alexandrahillpt@gmail.com. And you're more than welcome to email me, find me on social media. Like she said, I'm very active on there, and that's, you know, another way that we can, as therapists, really fight disinformation, improve access to care, especially in oncology. How many times do you see a TikTok or something and you're like, oh my God, that's snake oil? Like, it's not even true. Like, we can do something about it. And we need to show up for, again, for our patients and for everybody out there that is trying to find information that is evidence-based and true and relatable. So my call to action for you, get on social media.
Absolutely. Couldn't agree more. This has been so, so great. Thank you so much for your time. We really appreciate it. I feel like I just am constantly learning from you, and it really helps, honestly. And so we really appreciate it. Thank you.
Yes, absolutely. Hi, Kathy.
Perfect. Okay. I'm gonna this video is recorded, so we're gonna upload it with your permission if that's okay to the
Yep.
APTA Oncology. I think it's the YouTube page that we do, and we'll probably send it out through the listserv as well. But I really appreciate your time. It's been really wonderful.
Yes.